computer. Okay, good afternoon, everybody. It is Fertility Talk Live, and today we are talking to Dr. Coetsee. He is from the VItalab KZN branch, and today's topic is how to improve IVF success. So there's quite a few of you guys who are interested in this talk, because I think quite a few people are actually going through the IVF process. And it's always good to learn about what you can do to improve your success rates of IVF, and especially because it's an expensive exercise, we'll call it. We obviously want to make sure that we do everything as best we could for the best outcome. So again, we're talking to Dr. Coetsee, and thank you, Dr. Kobus, for giving us your time. And I know you've had a very, very busy morning doing, like I said, doing great things. So thank you very much for joining us today.
Thanks so much, Leanne. Thanks for having me, and welcome to all your listeners, well, viewers for that matter.
Yes.
Yeah.
Doctor, if you could just give us just a quick introduction of where you are and what it is that you do.
Yeah, so I'm the director here at VItalab KZN in Umhlanga. And we've been a joint venture with VItalab in Sandton since December 2019. And yeah, as a big group, we offer all the services that you can think of, and with good success rates, and yeah, one big happy family.
Awesome, doctor. So again, as you said, we're talking about how to improve IVF success. If you guys, if any one of you have any questions regarding IVF and you're going to be doing IVF soon or considering it, you can please put it in the comment section. So we'll take a few questions at the end. But for now, doctor, how do we improve the success of IVF? What is it that we can do?
Yeah. So Leanne, if you ask that question, it can be for two reasons. Either that you are planning to do IVF and you want to maximize your chances of success, or you've had an IVF cycle and it failed. So obviously it's always better to prevent something as to try and treat something. So normally when IVF is unsuccessful, there's always three things that we look at. The problem can either occur before the embryo formation. Other problems can occur after embryo formation, and we need to look at all of those individual reasons why it fails. And obviously the third one is at the time of the embryo transfer. So maybe with that in mind, let's go and see what problems can we encounter prior to an embryo formation, and then see how we can improve that. And when we stimulate a patient for an IVF cycle, excuse me, we always assess the ovarian reserve of the patient beforehand, so that we know how our stimulation can be tailored for that specific patient to get the maximum effect. And yes, we want eggs. And if the patient has got a low ovarian reserve, we know that we may get less eggs, and that may be a problem. I'll get back to the egg reserve a little bit later, because that's also the reason why we sometimes have problems after the embryo formation in terms of embryo quality. The other problems may be a technical difficulty when we retrieve the eggs, and that may be because of a patient, for example, with endometriosis, and the organs are stuck together, and it makes it difficult to get to the ovaries. It can also be due to fibroids, distorting the uterus, making access difficult. Another problem before embryo formation may be due to fertilization problem, and that's where we have to look at the male. And we should never forget the male, because up to 40% of couples trying to have a baby, there may be a male problem. and fertilization of the egg is obviously important in that regard. So the men, although there's not overwhelming evidence of it, should always stop smoking, because it's just in general good health. And we see often marijuana use that obviously can affect excessive alcohol intake, and then also obesity. So for men, it's also important to be within a normal weight limit.
Yeah.
If we look at the problems after embryo transfer, that would be the embryo quality. So now we've got the the embryos, they formed, but the embryo quality is bad. And that may be because our patients are older, and the older the patient is, the less eggs we expect, the less quality embryos we expect, the less implantation we expect, and even if they do fall pregnant, we expect a higher risk of miscarriages.
Yeah.
So I want to stop there for a short while and just talk about egg reserve, your ovarian reserve. And I think every lady should know what their egg reserve is. When you go for your general checkup with your gynecologist every year, still not planning on having babies, ask your doctor, please do an antral follicle count. That's where we do an ultrasound, assessing the ovaries and count how many follicles we can see. That gives you a fairly inexpensive, you're already paying for the ultrasound anyway, inexpensive way to assess how many eggs you've got.
Okay.
If the doctor finds it difficult to count, there's obviously the blood test that you can do, the anti-Müllerian hormone blood test, and that would give you also an indication as to whether you're still good to wait to have a baby or to speed up things. Because remember, IVF can't cure age-related fertility. And that's a misconception that patients have. They come at 40 and say, I want to do IVF because I'm struggling to fall pregnant, and now everything will be honky-dory. And it's not true. So we have to get our patients to come to the clinic sooner than later. And one of those sooners will be when your doctor is able to pick up that there may be a problem.
Okay.
Then just quickly, I'm just going to go through the framework if it's okay, Leanne.
Yes, yes, of course.
Yeah, the next thing would be when we place the embryo into the uterus, the receptivity. So we have to make sure that the uterus is normal in terms of size, in terms of shape. We have to make sure that there are no fibroids, and especially the fibroids that are pushing into the cavity. Those ones are notorious affecting our results. That's sorted. And then obviously, if you're a patient that had transfers before that failed, then there's the ERA test. The ERA test will help us to identify your personalized window of implantation. And by doing that, we can improve your chances of success with the next transfer. And the last little bit of my framework is the embryo transfer. It needs to be done by an ultrasound. We sometimes still hear from clinics or patients coming from other clinics where no ultrasound was used when placing the embryo. Obviously, ultrasound guidance, placing the embryo is important, and obviously soft catheters, etc. But those are more technical things that our viewers may not be familiar with.
Okay, that is great. Do you mind if I ask a question? I've just got a question from one of the viewers.
Yes, 100%.
Okay, for a patient with multiple embryos frozen, is it best to transfer more than one embryo at a time to increase chance, or is it better to just transfer one? Okay,
Leanne, you're now talking to the conservative doctor.
Okay.
I believe in a single embryo transfer. But obviously it will depend on a few things. First of all, how old is the patient? Because as the patient age increases, according to our guidelines, we can transfer more than one embryo. And if they are 44, we may even do 5, 6 embryos. And the reason for that is because we know as patients get older, there are too many abnormal embryos. So that way, by placing more embryos into the uterus, transferring more into the uterus, is to increase your chances of success. But I believe if you assess a patient properly, you do whatever you can to improve the quality of the embryo as per my framework. You make sure the uterus is receptive and you do a good transfer, then your chances of success is very good doing a single embryo transfer.
Okay.
Other thing is also, if you have a genetically tested embryo, so we can test the embryos before we transfer it into the uterus, then we also tend to put back less embryos. And I understand patients' concern regarding this topic. Some of our patients are unfortunately not lucky in terms of that there are good quality embryos, and they have to look at an egg donation program, but they now have had 3, 4, 5 embryos transferred into themselves with their own egg, didn't work, and now they try and catch up a little bit and go with an egg donation program and then transfer to embryos. And remember, if you go with an egg donation program, you increase your quality of your embryo, and actually you should then transfer less.
Yeah, because that was actually my next question. So thank you for going ahead with that. Because I was going to say, I did a talk a while back, and what the doctor had mentioned was, it's as if your 30-year-old you basically, or if it's your own eggs that's been frozen and you're using it that was frozen when you were 30, it's as if you are 30 and now doing IVF. So we always encourage women to, if you are busy working, you got your career, you're sorting out career, have a look at going into actually getting your eggs frozen. Am I correct, doctor?
Yeah, Leanne, that's what's called social freezing. But, I think it's social sounds like it's something that you can just discuss over a glass of wine, and then you decide with your friends, let's freeze our eggs, which is not true. I think each and every patient has got their own certain circumstances, which will determine when they want to start with their family or not. And that's why I said it's important that you know your ovarian reserve, because if your ovarian reserve is still good at the age of 30 and you want to wait until 35 before you start your family, yes, you should be okay. And then freezing of your eggs will most probably not be on the cards. But if you're the chairman of the big corporate company, and you're busy with your career, and you are now 33, 35 years old, and you don't plan on having a baby until the age of 40, it can make the difference between having a baby and a sibling for that matter. Because remember, when you do IVF, you have the ability to freeze those embryos and keep them. I always say it's kind of like a insurance policy, you never want to use an insurance policy, but if you need it, you need it.
Yeah. I've got one or two questions more, doctor. Janita van Tunda says, is it good to change clinics after 3 failed transfers? I've read that in some cases it's suggested to change clinics.
Is that a trick question?
So I know it's not just, we don't want to mention who the clinic is or anything like that. But she's saying, is it, would you suggest to change clinics and maybe have it you know?
Leanne, again, it's a difficult one because one needs to have all the information as to how old she is, what is the quality of her embryos, is she happy with the way her doctor explained to her why there was a failed previous transfer, why did it fail? Was a transfer done without assessing the cavity? And then only when it failed, then the doctor looked at the cavity. You know, there are lots of reasons. But I think if we always try and be open with our patients, give them all the information so that they can make an informed decision. So if a patient that's 44 and she's got 6 embryos and we've transferred those 6 embryos in 3 different settings, and it still hasn't worked and it wasn't tested, you know, then I don't think you can blame the doctor, because he gave you the information, he gave you the statistics as to what the success rate will be. And,
absolutely.
But if you're not comfortable with your doctor in the answers that you get, yes, a second opinion. And a second opinion is never to change clinics, you know? And when a patient of mine wants a second opinion, I have no problem with it. I always just say, please give me the doctor's name so that I can send him all the relevant information so that that doctor can make an informed decision. Because it's difficult for a doctor to start off with a new patient that has had a long history with a different clinic.
Yes, absolutely. I think it's you've answered that question so well, doctor. We can't just always blame a clinic or anything like that. I'll never blame the doctor or say something that the patient did wrong or something like that. You have to obviously look at all the facts. Just trying to get back into my questions. Sorry about that. Sorry, I just want to find there's quite a few questions that came up now, and I just want to have a look at it. Here we go. Sorry, guys. Okay. The other questions was, can you still test frozen embryos?
Yeah, so that's the other important thing to discuss with your patient before they start the IVF cycle, whether genetic testing, PGTA, is indicated, first of all, and whether that's a service that we offer to our patients. Normally, the best is to test the embryos directly after the 5 days of culture and then freeze them, because if you now have to test frozen embryos, it means you have to thaw them, biopsy them, refreeze them, and then if they are normal, you have to thaw them again. So obviously, yes, our labs are good and the embryos do survive, etc., but we don't want excessive manipulation of the embryos. But if you, for example, have 10 embryos and you've had 3 transfers and none of them worked, and you don't want to have another 7 transfers not knowing, it is an option, but it's something, again, that we discuss with patients before we go ahead to do something like that. And sometimes, especially if they want more than 1 baby and they have only 3 embryos left or whatever, then we would not rather suggest do another cycle, because if you only have 3 embryos, you're never going to get, well, God does beautiful things, but 3 embryos, 3 babies is not always possible. But then we would suggest maybe, listen, let's do another cycle. If we get enough normal embryos and test them and get normal embryos, then we don't have to test those others. But obviously, if you've got an excess amount of embryos of 7, you don't want to specifically then do another cycle to know whether they are genetically normal.
Yeah. Okay, I've got two last questions, doctor. Is it possible to implant the embryo with a fibroid of 5 centimeters?
Yeah. So fibroids, I always explain to my patients, it's like buying a house, and therefore position is very important. You know, it's position, position, position. So if that fibroid is more on the outside of the uterus, it's usually not a problem. But if it is definitely pushing into the cavity, it is usually a problem. Now, a 5 centimeter is our cutoff. Whether it can affect the transfer, yes or no. If there's nothing else that caused you to not have success, then sometimes it is indicated to go and remove that fibroid. But we do not have any studies to show that if we remove that fibroid, that you will have a successful outcome. So again, if it's a single fibroid, or maybe there are smaller other fibroids, and a small fibroid pushing into the cavity is more important than a big fibroid within the wall.
Okay, perfect. Then I've got a question from Lizelle. Lizelle, she's asking, do you perhaps know if SA have reproductive immunologists to help with multiple implantation failures due to immune problems? Lizelle, I've actually got a great professor that I normally have talks with. So please, if you can DM me, I'll give you their names. And then we've got the last one from Tatenda. I'm 36 with an AMH of 3.21. I have 2 transfers with 2 different clinics. The first clinic was a fail, and the second clinic ended up with a chemical pregnancy. What can I do to increase my egg reserve? But I only got 7, and on the 7, only 2 made it. Maybe she's talking about the quality. So you can't increase your egg reserve, but the egg quality, is that what she's talking about?
Yeah. Leanne, to me, it sounds like she's got polycystic ovaries. AMH, 3 point something, you said?
2.1, yeah.
Yeah. So egg quantity is not her problem, but egg quality. So I think it is a problem with the stimulation, the way she was stimulated, because if you only have 7 eggs in a patient with polycystic ovaries, it sounds like it's a little bit less than what we would expect. Obviously, it's a bit tricky to get the right regime in terms of the stimulation, but then afterwards, the quality of the embryos is obviously important. And she only ended up with 2. So it will be interesting to know what happened with the second cycle or the second clinic, how many eggs and how many embryos. But again, how old is she?
Yeah, there's no age. She's 36, sorry.
36, yeah. So at the age of 36, we know that, if I remember correctly, about 50% of embryos will test abnormal, you know. Yeah. So if you only have 2 embryos out of a cycle, that's not enough, you know. So you need to have a better stimulation program, cycle, so that you can get more eggs, more likely to have more embryos, and then more normal embryos.
Okay, awesome. Again, I just want to, the one last thing I'd say is, Munyandiwa, you can also DM me and I will give you the details of that professor. One last question from Lizelle is, how thick should the lining be for transfer? And can too thick of a lining cause failure?
Yeah, so we get pregnancies, or pregnancies can happen from 6 millimeters, sorry, and what the optimum thickness is debatable, but we normally try and get a lining to get to 8 millimeters, and you know, up to 14 millimeters is fine. That should not be a problem. You must just be careful. If the lining is thicker than 14 millimeters, for example, it may be that there's a polyp inside the uterus. that causes it to be that thick.
Yeah.
And obviously that needs to be addressed before an embryo transfer.
Okay, perfect. Thank you very much, Doctor, for your time. You've answered so many great questions. Yeah, thank you very much. The doctor is from VItalab in KZN. And if anyone in the KZN region is looking at doing IVF or want to see doctor and do, talk about your infertility, please contact him. I will put his details in the comment section. But thank you again for your time, Doctor, today.
It's a pleasure, Leanne. Enjoy your weekend.
You too. Bye-bye.
Bye-bye.